All right, I'm going to go ahead and get started. I will go ahead and apologize. I'm going to ask Kimberly to advance my slides throughout this process. So Kimberly, if you will just go ahead and advance. I hope everybody's had a great day so far. My name's Mandy Reimer. I'm a labor and delivery nurse at Bon Secours St. Francis Hospital. Thanks for joining us for our final Lunch and Learn for National Health Equity Month, or also known as National Minority Health Month. We are so happy to have you join us, whether this is your first time or your fourth. We've had an incredibly enlightening and energizing discussion over these last few weeks. While continuing to focus on COVID-19 health disparities, Roper St. Francis also felt that bringing forward a discussion on maternal health in people of color during this month was critical. And with the help of local and national professionals, we have discussed what is wrong, why it matters, what healthcare systems can do, what communities can do. And today, with the assistance of a national expert, we will discuss what you can do. So grab your lunch and ready yourself for some action. All right, Kimberly. This series is brought to you by Roper St. Francis Health, Women's Services, and Community Health Departments. Together, we believe that we can empower every woman to take charge of their health care through their lifespan and offer high quality, comprehensive, and equitable services customized to best fit your needs. It is our daily mission to heal all people with compassion, faith, and excellence. All right, on to a quick recap. Just discussing maternal mortality. When we discuss maternal mortality, we're talking about the death of a woman during pregnancy, at delivery, or soon after delivery. According to the CDC, about 700 women die per year due to pregnancy or birth complications. 2 out of 3 of these were determined to be preventable. When we talk about infant mortality, it is the death of an infant before their first birthday. In 2018, we lost nearly 6 babies for every 1,000 that were born in the US. That's over 20,000 babies a year. All right, Kim. South Carolina's maternal mortality rate in 2016 was 27.1. In 2016, it was significantly higher than the US average of 19.9. Internationally, South Carolina ranks 69th overall. For African American mothers, South Carolina's maternal mortality rate is 56.7, again, significantly higher than the US average of 47.2. South Carolina's maternal mortality for African American women compared independently ranks 97th in the world for African American women. That's higher than the maternal mortality rate in 11 developing low or middle income countries, which include places like El Salvador and Vietnam. Ultimately, us South Carolinians should be both sobered and motivated by how we fare in international comparisons of maternal and child health. Living in the most developed country in the world with a state per capita income more than 10 times larger than countries that rank above us in these metrics is astonishing and requires focus and energy around child health policy in South Carolina to redeem. Okay, Kim. As Kim stated in week 2, there is a difference in health equality and health equity. Like the picture on the screen, we cannot give everyone the same bike and expect them to ride successfully. That's equality. We have to cater our services, programs, and conversations to best meet the needs of the rider, and in our case, our mothers. And that's equity, our ultimate goal. All right. So week 4, what you can do. Please let us know. We want you to use the chat box. I'm going to talk about a few things here, and then our guest speaker will talk, but add your questions and we will go through them when we have the time. First and foremost, as partners of childbearing women and or as healthcare providers, we need to ensure that we listen. The CDC has created the Hear Her campaign and provides free reprintable materials for organizations to distribute. We highly encourage you to utilize these in your practice. Sorry, give me one sec. So the first thing we're going to do is look at what you can do on a federal level. Go ahead, Kim. Sorry, my notes got a little tangled up here, so I'm just trying to fix them. All right. As you see on the screen, April 11th through 17th was Black Maternal Health Week. This week has been recognized by and was founded by the Black Mamas Matter Alliance 4 years ago. It was just this year that President Biden and Vice President Harris declared April 11th through 17th as Black Maternal Health Week. During this week, Vice President Harris hosted a roundtable with Susan Rice, as well as several Black mothers who shared their stories. If you were able to tune in, it was really a moving roundtable. You can still find it online as well. Additionally, during this week, the Biden administration released their fact sheet, which was their initial actions to address the Black maternal health crisis. A few of the things that they are discussing is, of course, increasing investment. They want to invest $200 million to implement implicit bias training for healthcare providers. They want to increase funding for the Department of Health and Human Services Office for Civil Rights. They want to provide money to the Title X Family Planning Program. They want to prioritize investments in rural healthcare access, and they want to support women and young children by adding additional money to the WIC program. One of the biggest ways that they're hoping to improve this maternal morbidity and mortality rate is broadly extending postpartum coverage. Right now, Medicaid eligible women only receive 60 days of postpartum health coverage, and they are looking to expand that to 12 months. So those are just a few of the ways that the new administration is looking to improve on this health crisis. Additionally, you can move forward, Kim. Thank you. Our federal legislators and congressional leaders have also been looking to improve Black maternal morbidity and mortality statistics. And to build on these efforts, Congresswoman Lauren Underwood, Congresswoman Alma Adams, Senator Cory Booker, and members of the Black Maternal Health Caucus are introducing the Black Maternal Health Momnibus Act of 2021. The Black Maternal Health Act aims to, it is as I said, a Momnibus Act. It has 12 individual bills introduced by various members of Congress. But again, as you can see on your screen, it is very similar to the Biden plan of expanding Medicaid eligibility, accessing rural health care. The one thing that really that moved me was the number 11, the bill to invest in community initiatives to reduce levels and exposure to climate change related risks for moms and babies. So we're really bringing in, and understanding more how climate change not only affects, our earth, but our bodies and our moms and babies as well. You can get online to the Black Maternal Health Caucus, and you'll be able to read each of these individual bills and their terms. So I encourage each and every one of you to do that. All right, you can move forward, Kim. So at a state level, we have a bill that was introduced in January of 2021. It passed through the House, and then when it came to the Senate, they are sending it to a committee for review, but it is H3225. It is called the Dignity in Pregnancy and Childbirth Act. And this section creates a study committee, and the study committee is going to be examining the maternal mortality rates among non-Hispanic Black women in South Carolina and how this varies from the rates experienced by other women, maternal mortality data associated with perinatal care, including by race or ethnicity, to determine any statewide trends, statistically significant differences in maternal mortality rates among race or ethnicities, and reasons for the differences, and as well, all methods and practices that will improve rates of maternal mortality among non-Hispanic Black women in South Carolina. Okay, so here's where you come in. As I said, the very first thing you can do is listen. Listen, encourage your friends and family to listen. Then the advocacy part. You can contact your federal and state legislators. The South Carolina legislature has a website that you can visit, and I will connect it in the comments, where you can search for both your federal and state legislators, and you can contact them regarding these bills. Additionally, I encourage everyone that if you have not already, to go to Harvard's implicit bias test website and start to really gain a better understanding of yourself. This is where we're all going to start making changes, is within ourselves, to affect changes in our community. So I will link these two websites so that everybody can access them. So big time now. You can move forward, Kim. We are so honored to be able to present you Dr. Joya Creer-Perry, founder and president of the National Birth Equity Collaborative. Dr. Joya, as she is known to many, is a sought-after speaker on maternal child health and birth equity. Her National Birth Equity Collaborative creates solutions that optimize Black maternal and infant health through training, policy advocacy, research, and community-centered collaboration. The National Birth Equity Collaborative uplifts Black women-led organizations, guiding clinicians and researchers to center women, their families, and their stories. Dr. Creer-Perry is also an advisor to the Black Maternal Health Caucus, which, as mentioned, has introduced the Momnibus Bill of 2021. And a fun fact for those of you who were compelled by Dr. Rick Foster to watch last week's episode of New Amsterdam, Dr. Creer-Perry also assisted in advising them on that episode. So it is my honor to introduce everybody to Dr. Creer-Perry. Thank you.
Thank you so much, Mandy, for that incredible introduction. It's so nice to be here with you all. I always love coming to South Carolina. I have to come back again once we're all able, since I'm vaccinated now. So now we can come down and hang out with you some more. So just excited to be here and excited about this conversation. And I always love being in community with my friend, Rick Foster. So just saying hey, and of course, to the beautiful Kimberly, just thankful. So go ahead. So we're gonna have a dialogue. Y'all want me to talk a little bit about our work? So we have been working nationally, and our big thing that we're working on right now at the National Birth Equity Collaborative is to ask the White House for a White House Office of Sexual and Reproductive Health and Wellbeing. We recognize that we've learned so much from our colleagues in places like South Carolina about the things you've been trying to work on that are so siloed, right? Like you think about the work you're working on when it comes to maternal health, the work that you're working on when it comes to infant health, the work you work on when it comes to sexual health, like they become siloed. Different partners are working on different things. How do we create a community of well-being? How do we say that we want South Carolina to be a state that invests in the well-being of all people? Because part of the reason that we have these silos is we pick which populations we want to center. So are we centering babies today? Are we centering mamas today? We bring in the fatherhood initiatives at times. It's always a different population you want to focus on to have investments in those populations versus saying, how do we create a community that says everybody should have well-being, like all of us should have this? And so although I might have expertise in maternal and child health simply by virtue of the fact that I'm an OBGYN, so I stick to my lane of, I don't talk about, say, prostate cancer, because I don't know a lot about prostate cancer, but I can agree that if my job is to ensure that people have well-being, if someone enters who has a partner who has prostate cancer, part of sexual and reproductive health and well-being is making sure that they have access to the things they need for that partner who has the prostate cancer. So it's just reimagining what your role and orientation is when it comes to the work, and what your and how you can see yourself not just as only fighting for moms, or only fighting for babies, or only fighting for teen pregnancy, or only fighting for safe sleep. Like, we've siloed ourselves even inside of our work in the hospitals, right? If you're a labor and delivery nurse, what do you think about the NICU? What do you think about the moms once they leave and have the baby? How are we thinking about the well-being of the family from that handoff from the baby's out now, the candy's out of the wrapper, and the mom is there, and we're not really usually paying attention to, as my friend Dr. Allison Stubbe would say, the wrapper that was around the candy. And so then that person has to deal with NICU, which is a whole nother team of people who they might not know, who they might not have met yet, who they're not familiar with. And how do you make that warm connection for their well-being, right? So just reimagining, repositioning our focus. We made some definitions around pregnancy well-being, because when I complain all the time about pregnancy intention as a definition, people say, well, what are you going to replace it with? I'm like, okay, fine. So what would we do if we weren't concerned with just people's intentions? Where would the world be if it wasn't, you must intend to know better? Because the irony of the intention conversation is it says that people who make plans have great outcomes, and people who don't plan have horrible outcomes. I mean, we just know that's never been the truth, right? We know that there are many people who don't plan anything, but they have power and wealth. And so they can fumble through life and still do well without having this magical plan. And we also know there are people who are under-resourced who have lots of plans. They probably wrote down plans. They probably have an entire dissertation, but without investment in their ability to create wealth, without investment in their ability to get, you can plan to become a physician, but if you have nobody no way to pay for the tuitions, right? Since we don't provide free college in this country. So then it just becomes like this great plan. Where this really plays out is, I'm sure you might all be familiar with that. In every other high income country, they cover infertility treatment on public insurance. Can you imagine that? Like, it's just so foreign for us. Like, I can't even imagine. In the US, we've made infertility be something for rich, fancy people. It's not even covered on most people's employer-sponsored insurance, much less, can you imagine Medicaid covering in vitro fertilization in the United States of America, right? So that's this continuation of saying wealth is who should have access to things. And if you don't have wealth, then you're not as valuable. And so every other income country says, hey, my job isn't really to dictate based upon what you look like or your economic status, how you form families, be it if you never want to have a baby and you were purposely or childless by choice, and so you still are valuable, should have access to insurance and sexual pleasure and love and joy. And if you are under-resourced and you want to have more, expand your family, or if you're single and you want to expand your family, you have the ability to do that. Because our job is not to dictate what it should look like, because that's harming all of us, but to create an opportunity for people to have well-being no matter what their choices are. And our job is to support them. And it's a really different orientation of how I think about as an OBGYN, my role in providing care to patients. Like, I'm not just focused on the mom. And in training, okay, my mother's cell phone is going off. In training, they talk a lot about having access to, let me get my mother's phone. I will be right back. sorry about that. Welcome to pandemic presentations. But yeah, so anyway, so thinking about how do we undo these kind of hierarchies we all kind of have embedded in our minds, because it's that one, the infertility one, is really challenges us to think through, why do we think you should only be able to form families however you wish if you are wealthy? How did that become the American kind of norm around family means you must have wealth? Because we all know lots of people who are wealth poor who are great parents, and we all know lots of rich people who are horrible parents. So when we look at even the data for our own selves, the people that we know in community, people you might have gone to school with, you can say, I mean, I know some good parents who really were under-resourced and who needed investment in them in power building. And I know some rich folks who I don't really know about their parenting skills. And think about like how we create even solutions to do parenting classes for under-resourced people, as if wealthy people don't need parenting classes, right? Like all these assumptions that we just have built into this system without thinking about people holistically and without thinking about their entire ability to have well-being. And I do think you all have in South Carolina have an opportunity to really push that forward, because you have a lot of initiatives that you've been doing. You've been building a lot of work around maternal health, infant health, and I do know that hospitals have an important role in that. And thinking about yourself not just as the provision of care, but you're a large employer in most communities. So that the policies you make around paid leave, around support for your staff, all that matters for maternal and child health for your communities. How you model behaviors of ensuring that your staff feel well and have well-being and feel whole is also important for the community within which your hospital sits. And so thinking of yourself not just as a provider of care, but also a community partner and part of a system that is an ecosystem that includes the hospital and the community. So I don't know if it's my ramblings. Mandy, do you have some questions you want to ask me?
Well, we can certainly open it up. I was going to go through, we do have some chats and some springboards for discussion. Dr. Foster says, we all need to be willing to serve as maternal health equity advocates at the direct patient care, programmatic and policy levels, which is true. It takes a village, right? It's going to take all of us.
Yes, for sure. Yeah, do you have any follow-up, Dr. Foster?
Yeah, well, let me say first, it's great to see you again. And every time I see you, I'm filled with joy and hope. So thanks for being with us today. Yeah, what I was trying to get to, and maybe I should have added that we all need to be willing to come together and create a just and equitable culture, whether it's in our own organization, in our communities at the state level. Unfortunately, that's not what we have right now. We have a lot of good people, wonderful people, and organizations trying to work to address the inequities in maternal child health and well-being. I'm glad you presented that kind of the holistic view of well-being, and that healthcare is just one part of helping people to achieve well-being. I think we just getting comfortable with the role we need to play at all those levels. I was really touched, some of you probably, I don't know whether you saw it or not, but Tyler Perry's speech at the Oscars, when he was talking about, not hating and responding to hate with love, about getting in the center of the room, the first thing I thought about was how we need to all be willing to get in the center of the room around maternal health and infant health and well-being. And so any additional insights you have as far as how we do, and I appreciate your reference to the work we've done in South Carolina, but the reality is, like a lot of this work, it's still very hard to make sure that at the end of the day, it's equity focused first.
Yeah.
And so we sometimes see widening of gaps unintentionally, but how do we start making where equity is at the beginning? Is it equity first?
Right.
And then get comfortable with it. The rest will come along if we focus on equity first.
Yeah, I do think, thank you, Rick, for all of that. I do think that we are working with the American College of OBGYN to work on what's called respectful maternity care. And what we started with was interviewing Black birthing people around their experience of care. So respectful maternity care is a term that's used globally that we don't necessarily use in the US or any other high income nation. So the WHO, and a lot of times when people talk about it, they mean things like physical abuse, right? So like if you're in the Congo and you have a baby, there's a risk that when you're acting up, they might physically hit you. So we say, well, we don't do that in the United States. We're not, people are not on labor delivery hitting you, but we are doing things like refusing to give you pain medicine. Like we are doing things like cutting an episiotomy without consent. Like, so we like to act as if we're doing so much better, but some of the stories that happen in other countries that are way less resourced than we are happen right here in South Carolina, in Brooklyn, in Tulsa, Oklahoma. And so so to your point about how do you center and not widen the gap, you have to first really understand and believe that the solutions lie within the people who are the most impacted. And that's a very different orientation. We are so accustomed to what we call trickle down public health, right? So like we know the best, we're sitting in this office, we're sitting at the CEO suite, we're gonna do these strategies. What people need is education, we need to give them information, they need to come to the doctor's appointment, and we need to make sure that they have, these things like cribs. And so those are our strategies. When we make up the strategy without actually listening to the people, we create strategies that widen the gap, because people don't just need information, right? That goes back to what I just said earlier. So it's not like every conversation starts, it's just health literacy. That assumes that people who are high resource know everything about their bodies and are so health literate. Have y'all talked to rich people? They don't know anything about their bodies. Like, this is a fallacy. This is not a fact. They can't ramble on. They can't, this idea that they magically have so much more knowledge about their bodies is just not true. They have a lot of myths. They're taking all kind of herbs to fix things that don't have anything to do with health. Like it's just not a, so these assumptions we have that people who are lower resource just need more information is a false premise, right? What they need is access to power and wealth. They don't just need pamphlets and information about what they should be doing with their babies. And I'll give you, when we go to communities and do focus groups, we're usually hired by a health system like yours. And they say, come tell us what the community needs. And they start with their premise of what they think it is. So they'll usually, almost always, is we've decided that we want to work on increased access to prenatal care within the first trimester. And also, usually in the beginning, it used to be a safe sleep. We want you to talk to them about how they put their babies to sleep and what's happening with babies, right? So those were always like the public health strategy, the hospital strategies. So when we get to the focus group, we would ask the mom, so do you know where you can get care in the first trimester? Yeah. So why don't you go? Well, because I can't get on Medicaid till I send this form to the state. That's not them lacking information about entry to care. In fact, they know all the steps. Or they would say, well, when we go, all they do is blame and shame us. They wouldn't use the words blame and shame, but they are articulating the words blame and shame. So they feel like the system is telling them they have to come in so they can just get fussed at and told how they shouldn't be pregnant and how everything that they're doing is wrong. And so I wouldn't sign up for that. Like, why would I miss work, miss hours of being with others, other things, so I can go get fussed at and blamed and shamed? I wouldn't go to a doctor's appointment either. So this fallacy that they just need to know and they need to hear, that has never played out in any conversation we've had when you actually talk to the birthing people. They know that there's a clinic down the street. They know that they could go but there's so many barriers that we create. We create the barriers, including how we disrespect them and how we think about them. That is a barrier to their care, because they're not going to come if they think if they know that you're going to treat them poorly. Because I wouldn't go, right? None of us would go. We don't go to a doctor who treats us poorly. We change doctors. If you ever walk into a doctor's office and they treat you bad, you're like, I'm never going back there again. We expect low resource people to be like, well, I'm just happy he sees me. I'm just happy to be here. And they're not. So they're not going to go, right? So, and then we blame them because they don't go. So it's just like a circular thing. So I do think for me, what I hope that the more that people like you, everybody on this call, can really reorient their thinking when it comes to Black people or people who are low resourced or rural folks, that they're not just not showing up because they don't care about themselves, or they're not their barriers to care. The systems and the policies and the structures have been the barriers to their care. And so once you change that orientation, you start thinking about your strategies very differently. So we don't get called as much to do safe sleep things, because every time we would go, when we talk to the community, they don't need cribs. Like the problem wasn't that they needed pack and plays. There's a bunch of pack and play programs. They don't have heat. Who's working to make sure that their apartments have heat? They have rodent control. Who's ensuring they're worried about their kid being eaten by a rat? So of course there's co-sleeping, right? So you can't only focus on individual behaviors and then keep blaming and shaming communities about safe sleep without undoing the harms that make them want to co-sleep in the first place. So those are the kinds of moments that we talk about. Yes.
Dr. Joy, I had a question. So you said something that I think is so important. We use the word empower so often, but I think power building is what I'm going to transition to, because it's two simple words that most people understand, and it carries such a heavy weight. So in this power building movement and building this respectful maternity care and just and equitable culture, which sector would you say is most important? Is it the healthcare? Is it policy? Is it faith-based? Is it businesses? I mean, where do you think it's essential that we start in order to get there, not just in South Carolina, but across the country?
The sad part is I want to say all of it. so we need healthcare, we need private industry, we need policymakers, like everybody has a role to play. And part of it, and that's why the unlearning is the biggest part. So like if your business community believes that the reason that its workers are having poor birth outcomes is because they just have poor protoplasm, right? I've heard this in many of a medical facility. They use much worse language than poor, they add some other things before the poor protoplasm. So what that basically says, that providers and people think the reason that some groups have worse outcomes is they're just built that way. It's in their DNA, it's in their genetics, it's in their how they behave. So when they have poor birth, they don't have an incentive to modify as a business how they treat their staff, how they treat their employees. If you reorient them, if you say, even when Black and brown and rural and whoever folks, poor white folks, even when they have, go to the doctor, when they have insurance, they still have worse outcomes. What are you going to do, business? What are you doing around paid leave policies? What are you doing about childcare policies? What are you doing about equal pay policies? You as a business have a huge opportunity to improve birth outcomes in South Carolina if you had better policies within your business to support even just your staff. Even most of the staff, I've worked in many hospitals who a lot of the employees don't have health insurance, because it's cost. So when they think about adding it to taking it out of their check, if you're a person who's making $725 cleaning the beds in the rooms, and you're talking about adding some money to take out for health insurance, they're like, I'm not doing that. And then they're too rich to qualify for Medicaid. So then they're working in a hospital that if they got sick and when came in, they would go into debt and have to file bankruptcy. Like we create that, you know what I mean? That is so that's where you need the policymakers to undo that harm. Like why wouldn't we have a way for people to get access to health coverage without it being tied to a job, through, if you are poor, if you're under-resourced, it's not helpful. And the reason I try to use power building is to try to think a language is a funny, tricky thing, right? People take words and power building might eventually mean something else. But right now we can use it to mean following the lead, like we're building power, they are actually the lead. So empowering implies that I'm doing something for them. But building power, in theory right now, who knows where it's gonna go, requires us to actually let the community lead. And some concrete things like the trust building. I don't know if y'all ever heard me talk about this, but I would have never thought of trust building, because as a physician, I still, even though I do all this reproductive justice work, I still am deeply tied to white supremacy culture. I mean, I did years of higher education, and in my mind, you made an appointment with me. You don't trust me? Why'd you call my office? What's happening, right? So when we listen to the actual community and they build the power, they said, we would like a trust building visit. We would like a visit before we start talking about medical stuff, just to get to know you, just so you get to know us, to see us as an individual and you see me as an individual. That is antithetical to the way I learned to practice medicine, right? We're all like little things. We're never supposed, and patients get concerned when we don't change our voice, when things are urgent, when we don't seem sad or upset, but we're trained to do that, to see very like, we're like robots and we're just here and we're one thing and it's in and out. And actually patients want the opposite. When you talk to them, they're like, why didn't you get upset when you saw I was about to die? And we're like, because we're supposed to not look like we're upset. So it's just really reorienting all of that with each and every industry, starting with each industry, each area, first valuing all people equally, right? Like saying, we don't think that people just come broken. And so our job is to let them just die off or not invest in them because they're already broken. And that's really been the ethos. Survival of the fittest has been the American narrative since this country was founded. We did not know that fit meant landowning white men. At least I didn't know. Right? So like everybody else, if you're working hard, or that doesn't make you necessarily fit. So we don't invest in the well-being of all people. and believing that everybody should have access. Yes.
Thank you. You know, on my own journey to dismantle white supremacy in my life, and my privileges of it, those words have been important, right? And is the minute I never thought about it, empower versus power building, never thought about it, but the minute you said that, I was like, oh my goodness, that's giving that lead back to them, which is how it should be. So thank you for that. I love that. I have a question from Michelle, I believe. She says, what are your thoughts about having mobile units that visit communities for care?
Yeah, I think they're important. I mean, I come from New Orleans, and so Hurricane Katrina, if there weren't for mobile units, I don't know what we would have done. But what I don't want them to do is replace brick and mortar. So then that becomes this tension, right? Around, like, at one point I was in charge of, we had 80 different organizations with mobile units in New Orleans. We had to make a whole mobile unit task force. Like, it became a whole job keeping up with the mobile units. I was like, or we could go back and build some of these buildings that flooded, right? So, like, when do we transition from mobile to brick and mortar, and how do we decide that? That is going to be the trick, the balance between the two. But it's very important to be able to get to people where they are. And so that means definitely doing some mobile unit work.
Even being able, one of the discussions we had in, I don't know if it was in one of our chats here, but was even just having transportation, like, to that brick and mortar. Maybe you don't have a mobile unit, but you have transportation. And we know there's a Medicaid van, but then we have patients that say, well, it takes an hour for the Medicaid van to get to me, and then I'm late for my appointment, and then, you know, they won't see me because I'm late. So yeah, I think the mobile units are a terrific way to start, but having that, you know, really having that transportation to get into those brick and mortar facilities, a more reliable form of transportation.
And, you know, Mandy, the truth is, everywhere across the United States, we all complain about transportation. We have horrible transportation in this country. Like, if you go to Europe or any other country, you're like, wow, this is so nice, right? Like, you can get on a train and go everywhere in Europe. You can go to small towns, you can go to another country. We can't even get a train to take you from Charleston to the to the top of the state, right? Like, basic things. We were trying to get in Louisiana a train from Baton Rouge to New Orleans. And under the Obama administration, we got free money to make this high-speed train, but our governor, Bobby Jindal, turned the money down, right? And so what that tells you, and what that tells me, is this history and legacy of redlining, this history and legacy of neighborhood covenants is so deeply embedded in how we even talk about transportation that we can't get people to invest in actual real transportation in this country. South Carolina should have a much more robust transportation infrastructure. And I know that one hospital can't fix that, but the more you rally with your other colleagues around, people are dying in South Carolina because we haven't invested in access to trains, planes, and buses. Like, that's a very, transportation in and of itself is a need in rural, urban, and suburban America across the board. We do a horrible job.
So I have another question for you, but I wanted to also, if it's okay, respond quickly to Kelly's question about the Birth Outcomes Initiative. It's a great question about, you know, what's BOI, Birth Outcome Initiative, doing as it relates to policy. And I'm glad to say that the BOI is working with my old stomping grounds, Alliance for Healthier South Carolina, in a couple areas. One, trying to ensure that our Medicaid agency fully adopts the postpartum full 12-month coverage. And we're optimistic that we'll be able to figure out a way to make that happen. But there's also legislation like with the state employees around maternity leave. Exists now for both the mom and the partner, and have that incorporated for all, which is by far our largest employer population across the state. And there are other areas like that where we were pursuing from the legislative, I think primarily from the Black Caucus initially, having implicit bias, cultural humility training for healthcare workers, but I think it's kind of evolved into at least having a study committee to look at the best way for us to address the major racial inequities in maternal health outcomes. So there's some work being done. My question for you, and I've seen it over and over again, how do we find ways to help especially healthcare practitioners and other leaders, gain experiential learning. I was just on a call the other day with a nursing leader in our state who ended up having to go to New York City in the height of the pandemic related to military reserve, and went in there and they were going to equally distribute their staffing to all the hospitals. And they found out very quickly the inequities from one hospital to the other. And those that served, communities of color were just grossly understaffed and under-resourced. And they were able to convince them to change. She said that experience has totally transformed her. She really didn't understand both her white privilege, but also just how she needed to be responding to the community. And so I feel like that we need to have more ways to have that kind of experiential learning. Because the classroom's fine, but until you actually see it firsthand, really have to get in the middle of it. Sometimes it's hard to make that change.
Yeah, I mean, I think because a lot of us are training, our experience across the United States is that we train in spaces where there are under-resourced Black and brown bodies, and they're mass. So the place that she went to, New York, a lot of those places are probably the training sites, right? So like we take this vision of Black and brown means under-resourced, and we go out into private practice and we then continue that same kind of frame. So the experience really, really matters, right? Like, how do we have a cross-cultural like, how do you see the fullness of Blackness? There are some bougie, rich Black South Carolinians. They are there. I know them. Some of them are on this call, right? So how do you then say, because we don't see them, we don't experience providing care to this socioeconomic status of Black person, right? Like, that's not who you practice and experience your learning on. Those folks tend to not be in a teaching institution. They go like everybody else. Clinic is a word we use for poor people. They go to clinic. The rest of us have a doctor that we see as our provider, right? So clinics are filled with poor and under-resourced rural Americans and Black and brown bodies. And so the experience of providing and learning in settings that are across the board is really important. So Kaiser is a great model for that. And so I think a lot of times my friends who trained in a Kaiser, because they have like free care plus insurance all in one building, that just doesn't happen a lot across the rest of the other kinds of facilities. And care is very segregated by payer. New York is one of the most segregated hospital systems in the world. New York City has 2 hospitals on the same block. One has 90% Medicaid and one has 90% private insurance. So that segregated care creates the experience of learning. If you only go in one, you think this is what care is and this is what the people are. And then, so that's, for me, I've been trying to figure out, like OB, we don't train learning how to ever seeing birth center births or home births, right? So like, then we demonize both because we haven't had the experience of even seeing what any of these things are. So there's just a lot of opportunity for us to broaden our experiential learning by making policies where people are experiencing different ways to learn. So I don't know in South Carolina what the segregated care is, but I know it exists because it's everywhere. And so how do you then make sure that people who are like your friend who went to New York, she didn't honestly have to go to New York to see that. There are places in South Carolina that are under-resourced, that there are people who are Black and brown who are going to those hospitals who have staffing that's a hot mess, right? Who don't have a CAT scan, right? Who are like, oh, the OR had to close at 2 today because we ran out of whatever. Like that happens in South Carolina. It just might not be where she's working, and like spreading around the experiences even of who you work with in your state, to see the different resources that the state chooses to allocate to the different facilities is really important.
Yeah. Let's see, Kelly again just said, thanks, Dr. Foster. This platform is incredible in creating social media platforms to share experiences, can raise awareness and create learning. Yes, very, very true.
Do I know Kelly? I feel like I know Kelly.
You've probably met Kelly before. She's been very involved with the Birth Outcomes Initiative.
Yeah.
The other thing I want to say, kind of back to what you were talking about, is it also, and this can happen at the patient level as well as the system level. I remember when the AIM program, which is the program that was designed to try to improve maternal outcomes, first started up, they were looking at data in New York City, and they said, seems like some of the hospitals in New York City just aren't doing as well. And the first thought was, they just must not be giving as good a care. Well, the problem was, just like you've already touched on, it was a matter of the population they were seeing and the resources they did or did not have. And so we immediately want to go to that, well, it must be something wrong with the system, must be something wrong with difference. And the reality is the system is flawed,
Right.
but it's not an individual hospital.
Right.
In fact, they don't have the resources to do what they need to do.
Exactly.
And I want to say quickly, when I watched that New Amsterdam episode, I didn't know that you'd been a consultant, but it makes all sense now. Most scene is, and I love that medical director.
Yes.
Model, when he goes into the room and says stop, when they're getting ready to do the things that woman does not want.
Right.
And they all look at him and he said, don't listen to me.
Right.
Listen to her.
Exactly.
They can see that scene.
Yeah.
That's all we're asking. And in many cases, just listen to her.
Yeah. You know, and I would say that I was actually, as a provider, this is a culture shift in the practice of medicine, because I would get fussed at by my colleagues because I listened to my patients so much. I would get fussed at, I would get written up, and they would write in the write-up, you listen to the nurses too much. I was like, but they're here with the patients all day. I've been in my office. So this reorientation of who actually is a knowledge holder. It's like, for me, I always knew the people who were laboring the patient all day actually had way more information about what had been happening to her than me just showing up and I'm the authority and I know what's best. And the same thing, orientation is different for patients as well. So I just feel like in the opportunity, how I was able even to be a consultant, there's an organization called Hollywood Health and Society, and it's a nonprofit at USC that's funded through philanthropic dollars to try to change the narrative of what you see in Hollywood and health, right? So they have platforms where they bring people in to talk about, like, what does it actually look like? What does it mean during COVID to be a person who's an essential worker? And then you get to be on a little panel, and there's probably 30 writers in the room or more from different TV shows, different agencies. And then some of them after the panel reach back out to you and say, hey, I really want to write a story about what you said. And so that's what happened. So both The Resident, which was last year, there was a story in The Resident. And then this year, New Amsterdam, after doing those panels, people approached us to help them with technical assistance for their shows. And I do it again in a couple of weeks. And so I know there'll be another show probably next year, right? Because the writers, they get an idea of like how to build upon this new narrative and new way to talk about it. And you think about it, like, we have to push back, because if you watch any movie, there's advertisements for all kind of, they're messaging all kind of stuff to us. So they got Coca-Cola has a, and so we got this little small nonprofit at USC that's like trying to do the good health, like, can we get some good stuff in? We're like the lobbyists for good stuff in movies around health, versus people are putting all kind of other negative images, and so health.
Yeah, I know that I shall not even mention the network, but they did a movie at the beginning of Black Maternal Health Week, and I watched it with optimism, but I should have known.
Yeah, and so then that's a great example. So what I did do is send that, because there's a change.org like sign on around it. Like, there's a whole lot of movement around this movie that demonized the Black midwife and then the white OBGYN comes to save the day. So it has the same framing and narrative that is, and so truthfully, for that movie maker, they don't understand why we're upset. And I try to explain this to people all the time. They were doing what always is done. It's always the bad Black woman, we're either like the crazy person or we're gonna murder somebody. Like, so this narrative, we're snapping off on people, right? So they're just trying to figure out why we're upset. Because they're not doing anything different from what has historically been done in media when you talk about, Black folks. But Hollywood Health in the media does know that that's bad. And so I'm like, in addition to providing access to the writers to make sure that they have people who are experts to help them think about how they write things, also, I need you to hold accountable your folks when they don't. Like, what is the accountability? Can we do a sign on from writers around, like, please stop blaming and shaming, Black people. It's one thing to blame the patients, another thing to blame a whole Black midwife for like trying to murder and steal people. Like the imagery is bad. And, I'm trying not to be a conspiracy theorist, but it's hard sometimes.
It's very easy sometimes to fall down the rabbit hole.
Like, so Black Maternal Health Week, we got a crazy Black midwife. What's happening?
Right. Well, we have another.
Can I ask one question? So of you, Mandy, and Dr. Joya, what's one thing that you would get us and the other 33 callers? What's one thing that you would tell us or encourage us or help us build power to
Yes.
do after we get off this call? One concrete, tangible thing.
I would say I love like watching Dorothy Roberts YouTube videos around like race is not about and health. So you don't have to read a book, you just watch her online, and she's so great at like breaking down why all the ways that we have racialized things inside of health. You know, think every time you write single Black female, like why are you writing that? What does that add to the patient's experience? What does that add to their outcomes? Like why is that even necessary? So just spending some time unlearning the harmful things that we were all taught and all learned that were that are harming our patients. So concretely start with yourself. Start with learning, reading what you can. There's some resources on the Black Mamas Matter Alliance website that are excellent, including stuff by Dorothy Roberts and others, but just really starting with yourself. Once you get it for you, then you're so much more effective in helping the patients and helping your community and helping the hospital. I think so many times people want to jump and do something bigger versus starting with themselves. So start with you.
I would have said the same thing, but of course, Dr. Joya says it so much more eloquently. You know, I speak out of my own process, which is yes, unlearning. And so, yeah, reading books. I actually never heard of Dorothy Roberts, so now I'm going to dive in. There's, you know, some incredible organizations and people across social media that I do a good bit of interacting with that, you know, I learn from as well as unlearn from, I would say. But the work absolutely begins with you first. And that really goes for all of us because, you know, I think Dr. Joya could probably say it better than I could, but you know, even those of you that are people of color, you know, have been living under this mantle of white supremacy and you know, those are things that you have to unlearn too. So, all right, well, let's see. Zaporia, we are actually running very tight on time. I knew this would happen though, because we have such an amazing speaker, but Zaporia says the Birth Outcomes Initiative is also participating with the Improving Postpartum Learning Collaborative Affinity Group through CHIP Services, which is the Children's Health Insurance Program. South Carolina is also an AIM state. Our bundle of focus is currently hemorrhage, and we recently added the Birth Equity Work Group, which Zaporia, I would love more information on if you are willing to shoot that to me. And Allie asked if Dr. Joya would share the Dorothy Roberts. So she did. So everybody look in your chat, because there are a couple of links, both that I posted of the how to find your legislator, as well as the information, the website for the Harvard implicit bias. And then Dr. Joya linked a couple of Dorothy Roberts videos. So we have just about 3 minutes left. I want to make sure anybody and everybody that's had that has a burning question for Dr. Creer-Perry to ask it. So anybody else?
Can I just respond to Zaporia right just for a second? Just because it's a great example of opportunity. So when we first started doing this hemorrhage work, the assumption was we just needed to teach doctors to count hemorrhage better, that the problem was doctors and hospitals weren't counting hemorrhage right. But the truth is doctors and hospitals aren't listening to patients when they describe their hemorrhage, right? It's more about like, it's not that we need to learn better how to count laps. We need to actually listen to patients better around their hemorrhage. We need to, you know, so there's so reorienting, so tying both your birth equity work to the hemorrhage work is so important, because if you only teach people how to count laps without talking about listening to them, trusting them, valuing them, you're going to still see your outcomes are poor.
Perfect.
Yeah, I want to quickly say that and you said it earlier, but I wanted to come back to this. In addition to the self-awareness, the next thing is, and we've realized this, I think, more recently with birth outcomes, we've got to give a voice to those with lived experience. So those that are being most impacted by this, both at direct patient care level, but we got to do a better job of having them in the room, whether it's at birth outcomes meetings or any effort to try to improve this. If we don't have the voice from the community there, we're gonna miss what we need to be doing. We do it over and over again. You said it so well earlier. We've got to get better at that. and find ways to make sure that those voices are in the room and we listen to them, and we actually are able to demonstrate that we're going to make changes based on what they tell us.
All right, folks. This, I guess, will conclude our 4-week series, our Lunch and Learn series. I want to thank from the bottom of my heart Dr. Creer-Perry for jumping in with us today. It was such an honor to have you. And I also want to give a big shout out to Kimberly Butler-Willis and to Tara Taslana from Robert St. Francis Community Health for really making this happen for all of us. I hope that you all have registered through Eventbrite so that we can send you these our slideshows as well as all of the links. And that way you have this information and can continue to stay posted on the actions that Robert St. Francis Healthcare is taking on this subject. So with that, I say thank you so much for joining us, and thank you, Dr. Creer-Perry. It was just such an honor, and I cannot wait to spend some more time with you another day. So
Great. I appreciate y'all very much. Thank you.
yes, thank you.
Thank you, guys. Y'all have a great day. Thank you, Dr. Perry.
Thank you. Bye.
Bye-bye.